Good morning and welcome to the AETCM channel. I am Srinidhi Shivdasan, a final year medical student. We have with us our principal, Dr. Girish sir. Today we'll be discussing a case on mitral regurgitation.
So can we start now?
Yes, sir.
Here we have a gentleman who came to emergency room with acute breathlessness. He had a myocardial infarction 1 week back elsewhere. And there he was diagnosed to have mitral regurgitation because of acute MI. Okay. We had taken care of his airway, breathing, circulation. He's currently stable. He was started on BiPAP, last 6, everything. Currently he's stable. You can examine him for his clinical findings. You can start examining now.
Okay. So first we'll do the inspection.
Okay. Meanwhile, you have to check the pulse and BP
yeah,
also.
pulse and BP. So
what will happen to the pulse? You can even tell what will happen to the pulse in MR.
High.
It will be slightly higher volume. BP.
BP will be, if the patient is going into cardiogenic shock, it will be decreased.
So if the BP is slightly low, then you have to suspect a cardiac shock or hypertension due to systolic failure. Okay. So BP pulse is over. Now, next is
also assess all the vitals, GCS score.
Okay, GCS everything is good. Patient is fully stable now.
Okay, so now we'll go to the CVS examination. First we'll do the inspection.
So first of all, you have to check the JVP. That is very important.
Yeah.
So here JVP is slightly elevated. How do you assess the JVP? You have to add when we talk about that. Okay. Normally with 2-scale method.
Yeah. So the first scale you will place on the sternal angle.
So you can place.
Yes, sir.
Then second scale.
Second scale we'll place
perpendicular. Keep
at the highest point
of the jugular venous
pulsation.
Remember that jugular venous pulsations are multiple.
Yes, and carotid is single. Okay. Yes,
and you can obliterate the jugular venous pulsation. You cannot obliterate the carotid
pulsation. Okay. So we'll place, and it's usually supposed to be less than 4 centimeters, but
you have to add when we talk about that. Yes.
Here we're getting an elevated.
Suppose you are getting 3 in the scale here, 3 centimeter here.
So you will add 5 centimeters.
So that you will get central venous pressure.
Yes.
Okay. That is a right atrial pressure. Okay. You have to add when we talk about that. Yes. Okay. Now you can start.
Okay. In inspection, we'll first look at the trachea and the mediastinum. Here it appears to be central. However, in cases like any pericardial effusion, the mediastinum might be shifted to one side. So the next one that we see is apical impulse.
Okay. Can you tell me what is apical impulse?
It is the left lateral most
it is
visible,
the outermost, definitive, lowermost and outermost definitive cardiac impulse.
Okay.
Because lot of impulses you can see in some patients you can see impulses here and there.
Yes.
But it is the outermost and lateralmost definitive cardiac impulse.
Okay. So the here we're looking for the apical impulse. It should usually be seen in the left fifth intercostal space. We'll confirm it during palpation. Okay. Apart from that, we're supposed to see for any other visible pulsations.
What are the other common visible pulsations?
Epigastric.
Epigastric pulsation can be there, and like aortic pulsation, tricuspid pulsation, right ventricle. All are seen in the epigastric.
Then parasternal pulse. Yeah.
Right ventricle is there, left atrium is there. Parasternal pulsations are very important. That also you have to look. In second space pulsation. Okay. These are the common pulsations we see.
Yes. Then we'll also look for any dilated veins.
Okay.
For example, you can see any caput medusae.
Because almost all the patients who is having cardiac failure may have some liver enlargement, liver failure, all these things. So you have to look for abdominal veins also.
Yes. Okay. Then any scars, surgical scars, previous surgical scars. Now we'll move on to palpation.
Okay.
We'll confirm if the trachea is midline, like this. So here it is midline. Then we will palpate for the apex beat.
Okay. So keep your finger there. So keep your palm there.
Yes.
So that you will get an apical impulse. That you are just getting the the character of the apical impulse.
Yes.
What will be the character of apical impulse in mitral regurgitation?
It will be hyperdynamic.
Hyperdynamic. Just come and hit your finger
Yeah,
forcefully, but it will
won't
not
lift it.
Okay. And with your fingertip,
We will
localize. So
yes.
you are going to localize with your fingertip. You are getting the feeling of your pulse, apical impulse with your
palms.
palm. So where will you look for what is it? Murmur, palpable murmur.
At the
Thrill.
apex.
No, which part you will palpate? With
The
this part.
base of the fingers. Here also I can feel that the apex beat is shifted a little to the left and downwards, so that indicates left ventricular
So
hypertrophy.
left ventricle enlarges, apex
Yes.
beat will shift outwards
And downwards.
and sometimes downwards.
Downwards.
That means left ventricle is enlarged. And if you are getting a thrill there,
So a thrill.
you are getting a thrill in systolic or diastolic, what does it tell you?
That
It's a definitely
cardiac
lesion. That's
lesion,
all.
yes.
A thrill always indicates a lesion, because sometimes when you are auscultating, you may get a murmur, but if you don't get a thrill, that doesn't mean that that's a problematic murmur.
Okay.
But if you are getting a thrill, definitely you have to make a diagnosis of cardiac lesion.
Okay.
So you are getting a shifted out and down
Yeah.
apical impulse, which is hyperdynamic in nature.
That's about the apex beat.
Okay.
Then we will
Again, parasternal heave.
parasternal heave. The right ulnar
You
border.
can simply keep a scale.
Yeah.
Then you can watch it.
Yeah.
So when the scale is moving, just keep it like this.
Yeah.
So you can see the scale
Any
will be
movement.
moving like this.
Yes, okay.
Then you can keep your
Right ulnar
hand.
border
Okay.
on the left
Okay.
sternum.
So you keep it there. So there will be pulsation. That is parasternal heave.
Yes.
So what is the difference between apical impulse and parasternal heave?
Parasternal.
Both are ventricular,
Yes.
right? One is right ventricular, one is left ventricular. Okay. So both should move together.
Okay.
Normally both should move together. Suppose one is moving first, like your parasternal heave is moving first and apical impulse is moving after that, then it is a left atrial parasternal heave. So parasternal heave can be right ventricular or left atrial.
Okay.
So depending on the timing of the lift, you can tell whether it is a left atrial parasternal heave or right ventricular parasternal heave. Okay. Then where else you palpate?
Then
Second space.
Second space.
Second space is always you have to check.
Aortic and
pulmonary area. Whether any palpable thrills or murmurs or any sounds, everything should be checked. Okay. So palpation is over.
Then percussion.
Okay.
We'll start with the apex itself, the place where we felt the apical impulse.
So you can percuss. Okay.
You just move your wrist.
So what you are going to tell when you are getting the apical impulse and percussion note on the same point? What you are going to tell?
That dullness
corresponds to the apical impulse. That means he is not. Sometimes what will happen? You get a dullness. You get an apical impulse. Apical impulse will be more medial to dullness. That means he may have pericardial effusion. Okay. But here both are in the same side. Means it is all. There is no possible pericardial effusion.
Then you will percuss on the tricuspid area.
No, one is you percuss here.
Yes.
That is you are confirming your apical impulse. Then you have to percuss in the second space, because most of these patients can have pulmonary hypertension.
Okay.
So that space may be dull. Okay. Then other areas like you told.
Yes. Then the right.
Percussion has got a very limited role in cardiac examination nowadays, because it is not going to give any information. But even then, for completion's sake, we have to do it. Okay.
So percussion is complete. Then we will do auscultation.
So auscultation is very, very important in cardiac this one. So how do you auscultate?
So we
have 4 areas: mitral area, tricuspid
area, pulmonary and aortic area.
You tell me all areas, what you hear.
Okay.
So normally what all things you are going to hear?
S1,
S2, that's all. S1, S2 in mitral area, tricuspid area. S2 you are going to hear in the pulmonary and aortic area.
Yes.
Okay. So here in mitral regurgitation, how you are going to write your clinical finding in mitral regurgitation? Auscultation.
So here in the apex, I can hear the S1 is it's It's a weak S1.
S1 is soft.
Is soft.
Okay, S1. I'll tell why S1 is soft. One is S1 is soft.
Because it doesn't close properly. The valves
doesn't
don't close properly. Then
What murmur you are getting?
Yeah, here we're getting a pansystolic murmur.
You are getting a pansystolic. Pansystolic murmur means you should not hear the first heart sound. That is masked.
Okay.
First heart sound is masked, and you are getting a pansystolic murmur. Okay. What happened to the second heart sound?
Second heart sound we will look for in the pulmonary and the aortic area.
Okay.
So I'm getting a wide S2.
Okay.
It could be because of the A2 is starts earlier because the aortic valve aortic valve closes earlier. So,
okay. So you are getting a wide but not fixed.
Yes.
Okay. When it is wide and fixed, the diagnosis is entirely different. Okay. So here the main finding you are getting in the mitral area is that there
soft
is a soft S1 pansystolic murmur. You didn't tell me where it is radiating. That is very important.
Yes. We'll also look if the murmur is radiating to the axilla or the base.
Okay. If it is radiating to axilla, which
anterior
leaflet is involved. If it is radiating to the base of the
then
heart,
the posterior leaflet is involved.
So that is also very important. Okay, so you are telling the murmur, you are telling the first heart sound murmur radiation.
Yes.
Now you have to tell me the grade.
Okay. We'll look if there is a thrill. Yes. Okay. Thrill is felt on the apex, so it's definitely grade 4.
Grade 4. Okay, that means that there is a definitive cardiac lesion.
Yes.
There. Now you have to tell me whether you are getting a diastolic murmur here, whether any S3 is there.
Okay. So we'll look for a diastolic murmur.
Okay.
Here.
Diastolic murmur should be heard with a bell of the chest.
Bell. So.
So that you have to look for.
Yes.
If there is diastolic murmur, what is the importance?
It indicates the severity of the MR.
Okay. Now S3.
S3 I'm able to hear.
Okay. So that indicates
left ventricular failure.
So what will be your final diagnosis in this patient?
It is.
So this patient is admitted with acute breathlessness to emergency room, possibly pulmonary edema. He had past history of myocardial infarction. Possibly they have made a diagnosis of MR. So we don't know whether it is related or not, but it is a final diagnosis MR. So by examining this patient, what is your final diagnosis?
Acute mitral regurgitation.
Mitral regurgitation is the first diagnosis.
Yes.
Due to
papillary muscle dysfunction.
Due to
myocardial
infarction. Is it severe?
Yes.
Why you are telling it is severe?
Firstly, I could feel the thrill.
Okay, then, you are hearing a thrill.
Yes.
So there is a definitive lesion. Then
S3
is there. So cardiac failure is there.
Yes. Mid-diastolic murmur.
Mid-diastolic murmur. That is a not hemic murmur. It's a flow murmur secondary to severity of the MR. Okay. Now you want to auscultate the lungs. Are you getting pulmonary edema findings? You have to see.
Okay.
We had given Lasix, but still he may have.
Okay.
Auscultate the lungs. You're getting coarse crepitation means what? You're getting coarse crepitation means what?
It's pulmonary edema.
It's a pulmonary edema secondary to heart failure.
Yes.
So finally, what is the diagnosis?
Severe mitral regurgitation with pulmonary edema.
Failure with pulmonary edema secondary to papillary muscle dysfunction due to myocardial infarction. That should be the complete diagnosis.
Okay.
So you want to examine next his lungs. Any other case, whatever case you get, you have to
examine the other systems.
You want to examine the brain?
Yes.
It is not possible to examine everything.
Yeah.
What you are going to look here?
If the
patient is admitted with hypoxemia, so you have to look for consciousness. GCS you have to check.
Yes.
Okay. Any stroke you have to check because he can have atrial fibrillation, stroke you have to check. Respiratory system?
Yes, we have to look because pulmonary edema.
Pulmonary edema is one thing. Second thing, pleural effusion. Pleural effusion you have to check. Okay. You have to check you want to check the abdomen?
Yes, because usually patients like this will have ascites.
Abdomen. Like organomegaly, like hepatomegaly, splenomegaly. Legs?
Yes, pedal
edema should be checked. Okay. So these are the common findings will be associated with this. Okay. Now how do you manage this case? So how do you investigate? What investigation you want to do?
First,
it is already investigated,
yes.
but you can tell your own investigation.
Okay, first we'll order for a CBC.
So you want to see a complete blood count.
Yes.
Why you want to see a complete blood count?
To see for any anemia.
So anemia is the most important trigger for cardiac failure.
Yes.
So that has to be ruled out.
Yes.
Then
apart from that, we'll order ECG.
ECG will be done for what? Why you want to take an ECG?
To see if there is any ST elevation.
Okay, you want to see any
ischemic,
myocardial infarction and you want to see any left ventricular hypertrophy
Yes.
or dilatation or not. So that can be done. And next.
Then echo should be done.
Echo should be done to see whether regional wall motion abnormality due to
Yes.
MI or any mitral regurgitation. What is the grading of the mitral regurgitation, pulmonary hypertension? Everything can be checked. Okay.
Then BNP,
BNP
to
is for
severity
what?
of
Severity
the
of the
heart
failure. If BNP is very high, 10,000, 20,000, then it shows a severe failure. What else you want to see?
Then electrolytes.
Which electrolyte you want to see?
Potassium.
Potassium is very important because we are giving lot of Lasix diuretics. Potassium is very important, but sodium is very, very important because patient can have volume overload and dilutional hyponatremia is possible. Okay, so you can check the sodium, but that doesn't change your management.
Yes.
Okay.
Then creatinine, urea, kidney.
Why creatinine?
Because the kidney could be affected because of the heart failure.
So heart pumping is bad means kidneys will not be effectively perfused. So that has to be done.
Yes.
What else?
Then liver function test.
Liver function test, you can get some amount of ischemic
Yes.
hepatitis. Okay, then.
Then ABG.
ABG, why you want to do an ABG?
To check for any acidosis.
Acidosis, respiratory acidosis there or not. Okay, then anything else you want?
Then
so basically these investigations are enough. Okay. Now how do you manage this case? This patient is having MR and cardiac failure. How do you manage a cardiac failure separately and MR with cardiac failure? First we'll see what management you give for a patient who is having MI with cardiac failure without MR, myocardial infarction with cardiac failure without mitral regurgitation.
So first, we'll see if the patient is hemodynamically stable.
Okay.
If the BP is very low and all, we'll give vasopressors like norepinephrine.
Noradrenaline can be started, then dobutamine can be started.
Yes, inotropes.
Okay.
Then here, we will see, to increase the cardiac output here, we will give, to increase the cardiac output, you can give
so basically we had myocardial infarction. That part you have to cover. What drugs you give to prevent further myocardial infarction? Antiplatelets? What antiplatelets you want to give? Aspirin,
yes.
clopidogrel, statin will be given for that part.
Yes.
Okay.
Yes.
Then cardiac failure, how do you manage? We are giving Lasix as an infusion or bolus dose in acute emergency, but you have to continue that. So Lasix tablet should be given. Along with spironolactone should be added. Okay. Then there are two drugs which can prevent ventricular dilatation. What are the two drugs? One is beta blocker, other one is AC inhibitor or ARB.
Okay.
Sacubitril valsartan combination is there, but beta blockers and AC inhibitor or ARB can be started. Okay. That should be given. Okay. Will you advise him to take more water or less water?
Less
water.
Because
water intake should be restricted. Salt intake
should be restricted.
It should be restricted. Same case is like that is a case in myocardial infarction with cardiac failure. Once the patient develops MR, what is the treatment then? We cannot repair the mitral wall because once it is regurgitated, we have to replace it. So this patient may require mitral valve replacement. Whereas in mitral stenosis, mitral valve.
Sir, we also give nitroglycerin.
Nitroglycerin can be given where? It can be given. In this patient also you can give.
To increase the
coronary circulation. If the patient is having chest pain, definitely we have to give. Otherwise also we can give nitroglycerin. That also can be tried. Okay.
Then definitive treatment is surgery, valve replacement.
Okay. So this patient may ask you, what should be my position when I am lying down? How do you advise? In bed.
Okay.
Can he lie down flat?
No.
No. So what should be the position? This is the position. This is called as propped up position.
Yeah, propped up.
So head end should be elevated so that his posterior part of the chest will move. Okay. There will not be any pressure. And When you are lying down, there will be a lot of fluid may shift to the intravascular compartment that can come to the heart. When you are lying down in this posture, that sudden accumulation can be prevented.
Okay.
Okay. So propped up position is very, very important. Anything else you want to see? Anemia should be corrected.
Yes.
So we have to correct anemia. If the patient is having anemia, that has to be corrected because all patients who is having anemia can aggravate the problem. Okay.
Okay.
Okay. Thank
Thank
you.
you.